Welcome, everyone. Larry Martin here again. I did make a mistake in putting the title on this. This is going to be Altered Mental Status, Neuro Emergencies. Chapter 20 is not in this presentation. I will add it later. So endocrine emergencies will be added at a later time. I'm sorry for that. All right, stroke. Third leading cause of death in the United States after heart disease and cancer. Usually strokes occur in the elderly population. More men than women have strokes, but strokes are more likely to be fatal in women than they are in the males. Family history, race has a lot to do with predisposing factors for having strokes. A lot of hospitals now have got stroke centers. These are relatively new in the world of EMS. Some of them are primary stroke centers, some are comprehensive stroke centers. You guys will always be taking your patients to the closest stroke center regardless of what their capabilities are. Just think, we talked yesterday about cardiovascular emergencies and having heart attacks. Just think of this as a heart attack to the brain. Some people actually even call it a brain attack. They have a lot shorter window to get definitive care with a stroke than they do with heart attacks. They typically have about a 4-hour window from the onset of symptoms to time for definitive care. Seizures and altered mental status also can occur other than just strokes, so we'll talk about these as we get to them. Seizures can occur as a result of either a really old head injury. I had a patient that was 19. He was shot in the head during a drive-by shooting when he was 2, and ever since then he had seizures. Brain tumors, metabolic issues. You could have things like hypoglycemia or hypoxia that can cause seizures, and also you can have what is just called a seizure disorder. They do every test in the world and they can't really figure out why you're having seizures. They can't find an underlying cause, so they just call it a seizure disorder. There's a lot of causes for someone having altered mental status. We see a lot of people who are intoxicated, head injuries, hypoxia, stroke, again, metabolic disturbances. Some of these things you can rule out. Some of them you really can't rule out. For example, like hypoxia, you can certainly put them on a pulse oximeter to see what their O2 sats are. Just because you smell alcohol on someone doesn't necessarily mean that the alcohol is the cause of them having altered mental status. Some people that have strokes tend to appear intoxicated, even though they're not. So make sure you do your due diligence and check everything that you can. Check blood sugars, check the Cincinnati Stroke Scale, which we'll talk about, ascertain if they may be having a stroke. Check your pulse oximeter. So these are some causes. You can have neurological malfunction such as strokes or TIAs. And what a TIA is, this is also called a mini stroke. They'll have the same signs and symptoms as a stroke, yet the signs and symptoms will go away on their own within 24 hours of onset. Seizures, head trauma, brain tumors. You see a pretty long list here of causes that can cause someone to have altered mental status. So again, sometimes this is easy to figure out. Sometimes it's a little bit more difficult. Some blood work may have to be done to figure out the underlying cause of the altered mental status. Now, what is a stroke? A stroke is an interruption of blood flow to the brain. Most strokes, they say about 87%, are actually caused from a blockage, and those are called ischemic strokes. The other 13% are made up of hemorrhagic strokes, or you have a vessel in your brain that just bursts and bleeds. The tissue that's deprived of oxygen can eventually die, just like the tissue in your heart can die with lack of oxygenated blood flow. Depending upon what part of the brain that the stroke is occurring will be the loss of function that you have. Once these die, then they're dead. Just like the cardiac cells, once they're gone, they're gone. It's a great thing that we do have the stroke centers now. If people would call 911 in a reasonable amount of time and we get them to the stroke centers in a reasonable amount of time, then there may be no lasting damage, especially if they're having an ischemic stroke. This can be an embolism that has formed somewhere else in the body and it's migrated up to the brain, causing a blockage in a cerebral vessel, but it also can be a clot that just forms in one of those vessels and is stationary, and that's causing the blockage of the cerebral vessel. Symptoms can be nothing at all to paralysis on one side of the body. When you think about someone having a spinal cord injury, we use the terms either paraplegic, which means they can still move their arms, or quadriplegic, which is they can't move any of their extremities. With stroke, we have what's called hemiplegia. So you are paralyzed or you're weak on one half of your body, so the right side or the left side. Atherosclerosis, just like we talked about with cardiovascular emergencies, atherosclerosis in the blood vessels is often the cause of someone having predisposing factors of having a stroke. Now, with the hemorrhagic stroke, again, somewhere 10–20% of strokes are hemorrhagic. You have a vessel inside your brain that just bleeds. High blood pressure is a huge cause for this. Again, we talked yesterday about people, 75% of folks don't even know they have high blood pressure. But stress, exertion, these are also some causes of having a hemorrhagic stroke. So what do they look like? Well, they can look intoxicated, and they can have the slurred speech. They can be unconscious. They would have the one-sided weakness on the body, and that's called hemiparesis. So one of the things that you'd want to do to test this is put two fingers on each of your hand inside their hands and have them squeeze at the same time with the right and the left, and then that way you can see if there's any kind of weakness on one side or the other. There may be some facial drooping, so you'll have them smile, and if one of the sides of their face droops, then that's a pretty good sign that they're having a stroke. They may have some impaired vision as well. With a hemorrhagic stroke, especially if it is below the arachnoid of the meninges, they say that this is the worst headache you'll ever have. And so you typically don't get that big of a headache with the ischemic strokes, but you can certainly have it with the hemorrhagic strokes. Check their pupils. Their pupils are probably going to be unequal. They're probably going to have high blood pressure, again, maybe a little bit higher with the hemorrhagic stroke than with the ischemic stroke. These can cause seizures as well, so be alert for that. And they also can have some nausea and vomiting, and vomiting is a huge issue with folks who are having strokes because they typically can't control their airway or like they could before they were having a stroke. They may be aphasic, and this is especially if it's affecting the temporal lobe of the brain. They can be aphasic, which means they are not able to speak at all, or they can be dysphasic, which means that they're having difficulty speaking. Expressive aphasia is they understand you, but they respond with the wrong words. So this can be extremely difficult for you to figure out, because how do you know that anybody is understanding what you're saying? They may be nodding their head, but that doesn't necessarily mean that they understand what you're saying. Receptive aphasia, they speak clearly, but they can't understand what you're saying. Again, this can be very, very difficult because, like I said, how do you know if they're understanding what you're saying or not? And then the TIA is, as we said earlier, a mini stroke. They can have exactly the same symptoms as they do with a stroke, except that the symptoms will resolve themselves within 24 hours of onset. So here in the Dallas-Fort Worth area, we do what's called the Cincinnati stroke scale. Also, if you have seen some TV ads or some radio ads or some billboard ads, they're using the term FAST for the general public because it's a lot easier for them to remember that than it is the Cincinnati Stroke Scale. The FAST stands for facial droop, arm drift, slurred speech, and time. So I've got some slides coming up next that will show you how we're going to assess for all these and how we're doing the Cincinnati Stroke Scale. All right, so the F is for facial droop. Again, we're going to have the patient smile or show their teeth, and you see that the left side of it, or I'm sorry, the right side of his face is drooping. So that's a positive sign that they're having a stroke. You're going to lift the patient's arms, shoulder height, and then let go. And if you see one arm drift off, that's again a very good sign that they're having a stroke. The S is for speech. Ask them to repeat the phrase, you can't teach you can't teach an old dog new tricks. If they slur it, if they forget halfway through, if they don't say anything, then that's a positive sign that they're having a stroke. And then we need to know how long this has been going on. The best question that you can ask family members is not when did you start seeing symptoms? You need to ask them, when was the last time you saw them normal? And that really comes into play if this gentleman here was your father and he lived with you and you guys like to watch the news at 10 o'clock at night and you go to bed at 10:30 at night, and he was fine when he went to bed, but at 6 o'clock when y'all get up to drink coffee, he appears this way. Sometime within the last 7.5 hours, he's had these symptoms. Again, 4 hours is the magic window that we have to get these folks definitive care. So did this happen 30 minutes ago, or did this happen 7 hours ago? It's anybody's guess. So that's what you report to the hospital when you call into medical control, that he was last seen normal at 10:30 last night. If even just one of those three components of the Cincinnati Stroke Scale is positive, then they have at least a 72% chance of having a stroke that truly is a stroke. Some things that can mimic patients having strokes, they can be hypoglycemic. They don't have enough circulating blood glucose. They can be in a postictal state. This is where someone has had a seizure, and once they've had the seizure, they're in a state where they're sleepy. They may not be very responsive. If they do answer your questions, they're probably slurred. And then they can have a subdural or an epidural bleed. This could be from either trauma, or it could be from a medical issue as well. This was always one of the more frustrating calls that I would go on, because you can pretty much guarantee what's going on with the patient, but there's not just a whole lot you can do for them. You might want to go ahead and sit them straight up in the thought that they may be having a hemorrhagic stroke. And that way, gravity's going to be your friend at that point, and you're going to help decrease the amount of blood flow going to the head by sitting them up, and it may decrease the amount of bleeding in the head at that point. If they have an airway issue, then you would want to lay them on their left side to where it make it easier in case they, if they vomit, then it's going to make it a lot easier for you to clear the airway out on their side than if they were sitting up. These folks need to be taken to a stroke center, and in Dallas, I think most every hospital in Dallas County is now at least a primary stroke center, so they're everywhere, which is a good thing. Make sure you protect the affected limb. So if they're paralyzed on the right side, make sure that you take care of that right arm, that right leg. Don't have it dangling off the stretchers. You're pulling them out of the ambulance. Reassurance goes a long way with these folks as well. You can have them hold their right arm with their left hand, and that kind of gives them a sense that, well, at least I've still got my left side going for me right now. Maintain their airway and then get oxygen. Now for altered mental status of any other type of issue other than a stroke, secure the airway. If they need oxygen or if they need ventilation, then certainly you'd want to do that. always, 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 always check a blood glucose on anybody who is presenting with altered mental status. Suction the airway if needed, transport, and if you can, it would be great to try to determine the underlying cause of the altered mental status. You may even want to consider that they may be having a traumatic issue if an injury can't be ruled out, especially with the elderly. Sometimes the elderly will fall, nobody sees them fall. They may strike their head and then they don't tell anybody that they struck their head. And 2 or 3 days later, they're starting to show signs and symptoms of altered mental status. It certainly could be from a head injury that nobody knows about. And again, the patient never told anybody about the fall that they had 2 to 3 days ago. All right, seizures. Seizure, just think of this as an electrical storm in a patient's brain. It's just a sudden change in sensation, behavior, or movement caused by irregular activity of the brain. It's guesstimated about 75% of all seizures are idiopathic in nature, and what that means is they don't really know the underlying cause of that seizure, and these are the folks that typically are said to have seizure disorders. A seizure, some folks call them convulsions. It's a temporary alteration in their consciousness. I think that number's kind of high. I never got anywhere near 30% of my calls were seizures. I had my share of them, but I think that's a little bit high on how many of them actually call EMS. But it's estimated about 4 million people in the United States have got epilepsy, and again, they don't necessarily call it epilepsy anymore, and we certainly don't want to use the word epileptic fit. It doesn't seem as politically correct these days, so a lot of times they'll just say that they have a seizure disorder. So here are some of the causes of seizures. You notice that a lot of these are the same things that can cause altered mental status that we saw earlier. The one on the bottom, the eclampsia, when a woman is pregnant, this tends to happen during the 3rd trimester of pregnancy. Her blood pressure can go up. She gains a lot of water weight. She starts to dump protein into her urine, and that condition is called preeclampsia. When they become eclamptic, then that's when seizures occur, and you have a big issue with a pregnant woman who is actively seizing, because if she becomes hypoxic from the seizure, then obviously the baby, unborn fetus, will become hypoxic from the seizure as well. So this can be a complicating factor with a woman who is seizing and she's pregnant. Drugs and alcohol can cause seizures as well, even if they're trying to get off of the drugs or alcohol. Let's say you've got an alcoholic that's trying to quit drinking cold turkey. They can go through what are called the DTs, or the delirium tremens. They seize as they're weaning themselves off of the alcohol. Same thing with illicit drugs. If they're trying to wean themselves off of heroin, they can have seizures. Brain tumors, brain defects that they were born with. If you suspect any type of infection, most notably the meningitis, make sure that you put a mask on yourself and the patient as well, because you don't want that to spread to you and your family. Encephalitis is typically brought about by mosquitoes. They carry the virus that causes encephalitis, so make sure you'll probably see more of the encephalitis during the summertime than you would during the wintertime. Hypoxia, and then there's that word idiopathic, which means it's just unknown. Fever that's causing a seizure is called a febrile seizure, and that's the #1 cause of seizures in pediatric patients between the age of 6 months and 3 years. What happens with a febrile seizure is a child's running a low-grade fever with an ear infection, running a 99.2, 99.5 low-grade grade fever, and then all of a sudden it'll spike up to 104 degrees very, very quickly. It's not necessarily how high the fever got, but how quickly did it go from point A to point B. That just causes this electrical storm to go off in that patient's brain, and they have a seizure. Now, the younger they are, the less muscle that you're going to see, because they don't really have the muscle mass developed yet to get jiggy with it, so to speak. Their eyes may roll in the back of their head, their eyelids may flutter. That may be the only signs that you see of a younger infant having a febrile seizure. The number one cause of adults having seizures is they have a seizure disorder. They have been given medication to control the seizures, but they choose to not take that medication for whatever reason. Either they're feeling better, or they can't afford it, or whatever reason they choose to take themselves off of their medication. So there's different types of seizures. There's partial seizures, and there are generalized seizures. So a partial seizure is a simple partial seizure. There's no change in the patient's level of consciousness. They may have some numbness, some weakness, dizziness. They may smell or taste some unusual odors. There may be a little bit of twitching, but these can completely go unnoticed by not only the patient, but also people that are around the patient. With a complex partial seizure, they will have an altered mental status. This is typically from the temporal lobe of the brain. You may see a little lip smacking, some eye blinking, maybe some isolated jerking, but not general jerking like you would with a generalized seizure. So these, again, can be a little bit difficult to determine. The generalized seizures, like you see here, these are going to be a lot easier to see. So again, we have just some type of generalized electrical discharge in the brain on both sides of the brain, on both hemispheres, that are causing this generalized seizure, whereas the partial seizures are usually just affecting one part of the brain. So initially what will happen, most people will have what's called an aura. They either see something or smell something, taste something that makes them think that they're fixing to have a seizure. So if a patient does have a seizure disorder and they tell you that, I think I'm fixing to have a seizure, then you need to believe them, because they've probably gone through this before and they know that they're fixing to have one. They're even training dogs now to be seizure patient dogs, where these dogs can actually sense when that aura is coming about on that patient, and they can alert the patient that they're fixing to have a seizure. The tonic and clonic phase that you see here, those two together are called the ictal stage, the ICTAL stage. The tonic phase is where the muscles get very rigid. They may even have what's called a hypertonic phase, where they are just super rigid to the point that you could lay them between two chairs, 4 feet apart, and they'd be just like a board. And in the clonic phase is where they start to have the muscle contractions and relaxation of the muscles. And this can go on for 1 to 3 minutes, or this can go on for a very long time. Obviously, the longer a seizure goes on, the more hypoxic that they tend to get. They typically will be tachycardic. You really don't ever know what's going to happen with the breathing status. Sometimes they hyperventilate. Sometimes they completely quit breathing during a seizure. They may be sweating. They may have increased salivation. A lot of times they'll bite their tongue, and you'll see a little blood mixed in with the saliva that's coming out of their mouth. And then they have what's called a post-ictal state. Guys, they just ran a marathon in about 3 minutes. So they're tired. They're probably hypoxic as well. And they may even be hypoglycemic. And those three things together, even just one of those can cause them to be very sleepy and so forth after the seizure's over with. But you add all three of those together, and you're probably going to have a very sleepy, unresponsive patient, at least for a few minutes. We can have what's called a absent seizure, also known as a petit mal seizure. Back to the generalized seizure, some people call that a grand mal seizure, but we can call the absence of seizure a petit mal seizure. This can happen. You may completely lose touch with, you may stare off into space. There's no movement whatsoever of your muscles. You just kind of lose, you kind of off by yourself for just a few short seconds, and then all of a sudden you kind of wake up and you may not even remember it happened. So again, this can go unrecognized by not only the patient, but also the surrounding people as well. All right, so if they have, if you go out on a seizure patient, you need to find out what were they doing prior to the seizure, such as have they been doing drugs, have they been drinking, have they been taking their medication if there is a seizure disorder that's already been diagnosed. What kind of movements did you see? Did they just see the generalized jerking? Or did they see just one part of the body that was having some muscle contractions? Did they lose bladder or bowel control? What did the patient do after the seizure? Did they just lay there like they usually do? Were they snoring? Were they easy to arouse? And then how long did the seizure last? So there's not a whole lot we can do as EMTs, at least, while they're actively seizing. You want to make sure that the number one is they don't hurt themselves. So if they're up on a bed, if you want to surround the bed where they don't fall off, that's certainly fine. But putting them on the floor and having them around in a clear area where they can't pull things on top of them would be ideal. If you can, put them on their side so when they do start to salivate, maybe that blood from biting their tongue is going to make it easier for that blood and that saliva to come out. Good luck suctioning that patient because their teeth are probably clenched and you won't be able to stick your rigid suction catheter probably anywhere other than between their cheek and their gums. But again, if you can get it to drain down into their cheek, then it's going to make it a lot easier for you to suction if they're on their side. If they have any restricted clothing, make sure you loosen that. Don't try to hold them down. They can actually break their own arms or legs if you try to restrain them. And then don't place anything in their mouth. They don't swallow their tongue. I know a lot of people think that seizure patients are swallowing their tongue, and they don't. So don't try to put anything in their mouth to keep them from swallowing their tongue. Once the seizure is over with, then again, they really don't have the most secure of airways, so make sure you protect their airway, and again, keeping them on their side would be ideal in this situation. They probably are going to be hypoxic, so make sure you put oxygen on them. When you think about putting oxygen on them while they're actively seizing, again, if they're not breathing or if they're breathing very sporadically, the oxygen's probably not going to do them a whole lot of good, and it's going to be difficult to keep the oxygen mask on them while they are actively seizing, but you could certainly try it. Okay, now when we have either one seizure followed by another or more seizures without them regaining consciousness in between the seizure activity, or if they have a seizure, one single seizure that lasts 5 to 10 minutes or more, then that's what we call status epilepticus. This can be a huge deal because they're going to get extremely hypoxic from the status epilepticus, and if they die from this, that's probably what they're going to die from, is the hypoxia. So there's really not a whole lot more that we can do other than just our generalized treatment for seizures. However, because these are so prolonged or they don't have any kind of period of consciousness in between, we may have to get our back valve mask out and start ventilating these patients. Good luck with that as well. It can be very difficult to bag someone who's actively seizing. So try to get a blood glucose on them as well. Even your patients who just had a seizure, whether it's status epilepticus or not, if they had just a single seizure and now it's over with, you still need to check their blood glucose. Uh, as we've talked, you guys are always going to be with paramedics. So paramedics will already be there with you. They do have a drug that they can put up the patient's nose called Versed that can actually stop the seizure. That's a good thing. You know, the quicker you can get that seizure to stop, then the less hypoxic the patient's going to be. You may go out on people who are weak and dizzy. They may have what's called a syncopal episode. Syncope is just a brief loss of consciousness. You also may have what's called a near syncopal episode. You know, you feel yourself starting to lose consciousness. You sit down or you lay down and you don't completely pass out, and that would be a near syncopal episode. It can occur at any age. It's typically more common in the elderly. They don't do too slow or too fast of heart rates very well, and that's one of the bigger causes of weak and dizzy or syncopal episodes in the elderly is their heart rate's either too slow or their heart rate's too fast. But especially if you have a syncopal episode and you've never had one before ever, then it could be signs or an indicator of a serious underlying problem. This can happen to any age patient. If you're hypovolemic, whether it be from you bleeding out or you've got 3 days of vomiting and diarrhea, or you're dehydrated for some other reason, then you certainly could be dizzy and pass out. Patients could be hypoglycemic. They could be having a stroke or seizure. Some other causes would be alcohol and drugs. Carbon monoxide, we have a lot more of those cases in the wintertime than we do in the summertime in Texas. Panic and anxiety attacks. Again, with the elderly, most notably, the too fast or the too slow heart rates. People can have electrical system disturbances, whether they're young or old. Again, these are more likely in the elderly than the younger folks. And then sometimes people inadvertently stimulate their vagus nerve. For example, they may be sitting on the toilet and they're constipated and they're straining to take a bowel movement. They may inadvertently stimulate their vagus nerve, and that's going to slow the heart rate down to the point that they could actually pass out. So again, like with any of the altered mental status, try to do anything and everything that you can to try to figure out what the cause of this syncopal episode is. Get your OPQRST questions asked. What were you doing when this dizziness or this syncopal episode began? If they're still passed out when you get there, you obviously would want to ask bystanders. Does anything make this better or worse? Describe the dizziness. I mean, did you feel this coming on? You know, did you see the little pinwheel circling before your eyes? Did you feel yourself getting lightheaded? And were you standing up or were you laying down? Most syncopal episodes happen from a standing position. So that may be one difference that you may look for on trying to determine, was this a stroke? Was this a seizure or was this a syncopal episode? Syncopal episodes can typically happen from a standing position, whereas seizures can happen in any position, from laying down all the way to standing up. When did it start? How long did it last? Has this ever happened to you before? If so, did you go to the doctor to try to figure out what the cause was? If they did determine the cause, are you doing what you should to try to prevent this from happening again? Are you taking any medications for this issue? And then has there been any vomiting or bowel changes lately? Again, if they said they've had diarrhea or they've been vomiting for a couple of days, that certainly could be the underlying cause of them being dizzy and passing out. Give them oxygen by whatever method that you feel the need to. Again, loosen their restrictive clothing. Probably have them lay flat, and you may want to put them in Trendelenburg in this situation. And then if there's any injuries, like they may have struck their head when they passed out or whatever, then you would want to treat any injuries that were associated with this episode. So get their chief complaint. Unresponsive patients, obviously, you need to talk to bystanders or family. If no one's around, then look around the room. If it's in someone's house, look around the room and see if there's any medications that may indicate that they may have a seizure disorder or something of that nature. So if there's any illicit drugs, any empty alcohol bottles, things like that that may make you think that that could be the cause of them having altered mental status. Make sure you evaluate the patient's speech to see if there's any slurred speech that may indicate that they're having a stroke. So time is pretty critical for most of these. If they just had just a very simple syncopal episode with really no underlying cause, that's not that big of a deal. But most of these are a little bit more urgent than just I passed out. Try to get all the medications that they take and take them to the hospital with you. Let the staff at the ER see what the patient's been taking. If they've had a seizure, ask the patient or the family if they've got a history of seizures. Do a full body scan, if nothing else, to see if there's any kind of injury. Also look for medical alert tags that they may be having. They may have them in a necklace. They may have it as a bracelet. It may be something in their wallet that lets you know that they already have a pre-existing medical problem. And then we do the Cincinnati Stroke Scale. I wouldn't concern yourself with learning what the Los Angeles Stroke Scale is, because we do the Cincinnati around here. Again, we're doing the FAST, which is the same thing as the Cincinnati Stroke Scale. Make sure you do if at all possible, make sure you do a Glasgow Coma Scale on the patient as well. Doing an initial Glasgow, and then if there's any treatment that you did that may have made the patient better, then you can certainly do a follow-up Glasgow as well. You would certainly want the follow-up Glasgow to be better than the initial one. With bleeds within the brain, this can cause quite a bit of pressure within the skull, and that's going to compress the brain. So there is something called Cushing's triad or Cushing's reflex that we get with intracranial bleeds. Their heart rate is going to slow down because the vagus nerve that's in the brain is going to be compressed and stimulated, and that's going to cause the heart rate to slow down. The blood pressure, however, is going to increase. The body still has the wherewithal to realize that I've got to get blood up to the brain. That's kind of the most important guy right now. So the blood pressure tends to go up, and they have what's called a widening pulse pressure. And what that means is the systolic and the diastolic blood pressures are getting farther apart. So let's say you pick the patient up initially and their blood pressure is 120/80, and because they're unconscious, you decide to evaluate them every 5 minutes. 5 minutes later, their blood pressure was 120/80, and now it's 128/80. So that systolic is rising. Usually the diastolic will stay somewhat constant, but that systolic is getting higher, and that's causing that pulse pressure to get further apart or widen. And they get real erratic respirations. Cheyne-Stokes respirations is probably one of the more common respiratory patterns that you're going to see if they have increase in their cranial pressure. If the patient does have altered mental status, as we've talked, make sure you do check a blood glucose on them. If they're actively seizing, it's going to be all but impossible to get vital signs on the patient, so you may have to wait till the seizure has been terminated by whatever means to get vital signs. Focus on your reassessment. Focus on your ABCs or your initial assessment, your vital signs, and then any intervention that you've done, make sure that they're still responding to it if they responded to it initially. So any intervention that you're going to do upon your reassessment will be based upon what you're finding during your reassessment. For the most part, the strokes, the seizures, the hypoglycemia, the hypoxia, because we've got ways that we can measure that, so to speak, those are usually pretty easy to identify. But a lot of the other issues that can go along with altered mental status, they're probably going to have some tests done at the hospital. Like, unless they tell you that they have a brain tumor, you're probably never going to know they have a brain tumor. If they are not showing signs and symptoms of increased intracranial pressure, then you probably not going to know that there's bleeding within the brain. They're going to have to do a CT for that. So supplemental oxygen, again, don't let their SATs get above 99. If they are having a seizure, protect them from hurting themselves, clear the airway if you can. Good luck with that, that's all I can say. If you can keep oxygen on them, then that would be good as well. If they continue to have a seizure, then again, good luck with suctioning the airway, but you would want to try to get your back valve mask out and ventilate the patient with a BVM and transport as quickly as you can to pretty much any hospital in Dallas can take care of a seizure patient. If they're having a stroke, make sure you call a code stroke to the stroke center, and that gets them alerted, and they're going to be ready for you when you hit the door of the emergency room. And as we said, the quicker the care that they can get, the better outcome that they're going to have. Make sure you tell them when was the last time they were seen normal. Give them whatever you found during the neurological exam. You know, this would be like your Cincinnati stroke scale and so forth. And give them the ETA, so when you hit the door, they're going to be ready for you. So try to give them whatever you found with your GCS and your stroke scale. And then if there were bystanders or family that was there that saw the seizure, make sure you describe the seizure to the hospital to let them, again, have an idea about what type of seizure might have occurred. Okay, so this ends up altered mental status and seizures and strokes. And so here in just a few minutes, I'll put on endocrine emergencies. And the biggest thing you need to pay attention to in the endocrine emergencies will be the diabetes. So hope y'all are doing well, and I'll talk to you soon. Thank you.